we were
Deepak, is it
trying to.
okay if we start recording or should we wait for some more time? This
Oh,
is,
I was just going to go get some coffee.
yeah, please.
Give me 1 minute.
Then you can tell us more about the book that you're reading now. Yeah. In fact, Kita, this book came in 2002, but there was this one book which was To Err is Human. You know, that was the seminal book which started this whole patient safety movement in 2000. Right. And then we had a couple of publications which started coming one after the other. And then the timing of this book was so good. Complications. It turned out to be so good that was the time when the whole patient safety movement started, picking up the momentum. And this was like a layperson's, in a very layperson, non-medical language. I mean, I don't think we can say that there are a lot of technical stuff mentioned, but that helped, the book to pick up very quickly.
That's right. That's right. Yeah.
The timing of the release of the book was very good. I feel that. Yeah. So Deepak, please tell us about this new book, this another book which you are reading.
Right. So this, I got into reading this because of some of the debates that we are having in the world of ambulatory anesthesia. So in the US, most oral maxillofacial surgeons perform our own anesthesia in the office, non-intubated. So
conscious sedation, that's conscious sedation that you're talking about? Or?
That's an outdated term, so we don't use the term conscious sedation anymore.
All right.
And so we do.
Thank you for letting us know this. Yeah.
Yeah. So what we do is it's deep sedation, moderate sedation, or oral anxiolysis. And with deep sedation, anytime you give agents like propofol or ketamine, that's a general anesthetic. So I'm the chair of the Committee on Anesthesia for AAOMS, and I represent AAOMS with American Society of Anesthesiology. And actually just yesterday, a 3-year-old child died in a dental office in Kansas. And the model is going to be like thrown out because essentially it is a pediatric dental office. It was a nurse anesthetist and an anesthesia provider separately doing the procedure. And yet, the child dies, right? So pediatric dentistry and oral surgery have been fighting about whose model is better. And so there's a lot of debate, and I'm trying to understand how different other industries look at safety and human error. It's been a focus of my study, so that's why I picked up. So we tried to get Decker to come and speak at a safety symposium. He charges $100,000, Krita, and first class tickets from Australia. So
right,
AOMS said no need, find somebody else.
So. So this pediatric dentistry thing you're talking about, anesthesia provider is an anesthesiologist, fully trained. Okay.
But the thing is, so the end of the day, what we do, 20 minutes, set of third molars, 18-year-old healthy patient, right? You put an IV in, you numb their reflexes, you give them numbing medicine, and then you go to town. By the time you're putting the last stitch in, they're waking up.
Yeah.
And they tolerate that very well. Very different from a 3-year-old fully anesthetized in a dental office with an anesthesiologist outside a hospital that doesn't have any other help.
But do they tube them? They tube them, right?
They tube them. They actually tube them, and then they sit there and bag them. And what happens is these procedures, it's usually a special needs child too.
Yeah, right.
And then these are 4 or 5 hour long procedures.
Yeah.
And then they leave, right? And then they send them home.
I was about to say that the one instance that happened in Bangalore was like that. The anesthesiologist, I think they leave too early. Yeah,
they leave too early, and then they don't bring good help, and they don't. They have the sense of safety which fails.
Yeah, Exactly the same thing happened in Bangalore some years ago. The anesthetist left after the procedure, and then I think the child, fell asleep again and arrested. So when the procedure was done, everybody was around. But when this happened, he had left. Yeah. And
so the problem with that is then all non-anesthesia providers providing anesthesia outside the hospital setting get painted with one brush, saying it's not a safe model.
True that, yes.
And so that's what we are looking to fight. So the other issue in this is, 1/3 of an oral maxillofacial surgeon's income comes from doing anesthesia themselves.
Oh, is that right? So you're charging separately for that, is it?
Yes, you can charge. I have a general anesthesia permit in the state of Ohio. 6 months of our 48 months of anesthesia of residency training is spent as an anesthesia resident.
Right.
And then, our chief residents graduate with an average of 1,000 anesthetics. So that's an incredible experience.
Yeah, I've seen them in your OR. They're the ones who are doing minute-to-minute monitoring, isn't it? There's no one just next to them, though they're around. Yeah. So
a lot of people are joining us.
I can also see that when they come here, that they're interested in what's happening on the top end all the time.
They talk about Jacob all the time. They talk about how incredible some of the anesthesia techniques that for pediatric anesthesia especially.
That's right. Yeah. So I see that interest, and that will come only because you know what is happening and you.
Correct. Yeah. In fact, one of the things that Gawande talks about, how the failed bedside crike, right? Like the case that he has. That happens to us on a regular basis because we respond to the airway call. The airway pager is with us.
Okay.
That was our bane during COVID too. Our team ended up doing a lot of COVID trachs. That's how a lot of us got sick.
Okay.
I think in India, the situation is very different.
Practices are different.
Yeah, practices are very different. I don't know whether I would say that it is in a way if maxillofacial. What do you think in case if maxillofacial surgeons are not into anesthesia at the moment? You think we are ready for it? Something like I don't think we are ready.
I don't think
training wise, I don't think we are ready.
Somebody like me will not even attempt, and I've seen what they do in the American offices. I've been there, and when you start giving propofol and midazolam and fentanyl and all of them together, if you can't intubate, if you can't take care of the white, you are in a deep hole. So I don't think our people can do it. We have no background at all.
I think I would be very happy if our people do maxillofacial surgery well. We would be happy if they do our minor surgery.
I think this is a tradition only in America, right, Deepak?
It is. So
I have not seen this anywhere else. In Europe or elsewhere.
No. I routinely place LMAs on my obese teenagers that come in for teeth extractions. That's and then I keep them deep and I take their teeth out that way. But I'm set up for that. And my training helps me for that. Very different.
Yeah, true. And the nurses that are there in the dental offices, the oral surgery offices in private practices, are they also certified to do some kind of anesthesia?
Yes. So now we are actually part of this Committee on Anesthesia's charge is to create a community college-based course. To have a very dedicated oral maxillofacial surgery anesthesia assistant. So just
I think that also helps, right? Because they can do quite a few things when you are stuck doing something else.
Indeed. So, there is a dental anesthesia course. So if you're a high school graduate, you can go in and become a certified dental assistant course, So you can become a dental assistant. And then this would be a step up would be to not only consider being an anesthesia assistant in an oral maxillofacial surgeon's office, but also orthodontic assistant and things like that. So they're branching out.
Right.
Good jobs though.
Right.
Let's wait for, we have 35 participants. Let's wait for 5 more minutes and then we start because we have a long conversation. Yes?
Yeah, yeah, sure. Gopal's there.
Yes,
I can see Gopal.
Gopal says that. Yeah, Gopal. So, hello, sir. Good evening. I don't know if I can. There are too many things I'm doing together. Gopal, sir. Good evening. I'm so glad you came.
He's chatting.
Your friend. He's chatting with you?
No, on the chat.
All right. I'm already dealing with too many screens, so I can't. All right. I think let's get started before. Okay. Okay, let's start. Good evening, everyone. I take immense pleasure in welcoming you all for this very interesting session on discussion of topic of complications in the surgery through a book by the same name. During a prep meeting, when Deepak asked me this question, why a 20-year-old book for a discussion, it got me into thinking. I could come up with 2 reasons, one professional and the other personal. Complications in surgery are definitely not a pathway. They're very much part of our daily practice, just as they were 20 years back. So professionally speaking, this needs continuous discussion. For the latest statistics on preventable harm in healthcare practice, I've attached a PDF of the latest article, a systematic review for your reading, which is available for all the attendees. On a more personal note, I have a close experience of my own with complications. More or less at the same time when the book was released, I was a fresh postgraduate pass out, and I had entered the professional world with lots of dreams of doing good work. While being a junior most in the rug, when I found it difficult to remain quiet, witnessing complications caused by others, that's when I started losing jobs, 3 out of them. And practically, I was unemployable for quite some time. Well, that was 15 years back. In the current time of pandemic, in the last few months, we have been sitting on the heap of mucormycosis, some of the largest numbers in the world, the grave consequences of the medical negligence, ignorance, complications, whatever you choose to call it. The simple word is suffering. It is the helplessness of our patients and failing healthcare systems of our country that needs this conversation desperately and honestly. So instead of blaming one another, let us ponder deeply into the factors leading to this catastrophe with our esteemed speakers of today. In my opinion, the speakers of today are like the sun, the sun needs no introduction. And hence the speakers are also highly acclaimed in their position. I need to, Dr. Krishnamurthy Bonanthaya, he's a professor, he is an academician of a very high repute, and currently he is working in Bangalore Dental College and heading and he's also attached to Mahavir Jain Hospital in Bangalore. My second speaker is, just a sec, I'm facing technical issues. I'm sorry for this. My second speaker, once again, Dr. Deepak G. Krishnan, a very well known, he's a DDS and FACS, Associate Professor of Surgery, Chief Oral and Maxillofacial Surgery, University of Cincinnati Medical Center. He's also Chief Oral and Maxillofacial Surgery, Cincinnati Children's Hospital and Medical Center. So I with a very deep gratitude in my heart, I would like to welcome both our speakers today. Thank you so much for accepting my invitation and coming here today. Thank you so much. Yeah.
Thank you.
All right. So here, what I have displayed are the contents of the book. Now, this book is an elaborate one. You can see that there are 239 pages. And since we will be discussing this book in, let's say, 1.5 hours span. Good evening, sir. Welcome to the webinar. All right. So the book is divided into 3 parts: fallibility, mystery, and uncertainty. Because of the lack of time, we will not be able to discuss all these sessions in depth. At the same time, mystery and uncertainty are more random thoughts of the author, since it was his first book, and hence the ones who are interested and who find more interest can go back to the book. But the ones which we really find relevant to our conversation today of complications is the part which is based on fallibility, human fallibility. And that is the part we will discuss more deeply in the form of question answers. So I would be posing some questions to our speakers, and the discussion will revolve around them. There are around 4 questions that we have framed. And after each question, we will stop for comments from the attendees or any of their experiences. It will be open for discussion. So shall we start? All right. So Kita, I'll start with you. The same question will go for both of you. So my first question to Kita is, when a fallible human being is preparing to take the responsibility of another human's life, how, in your opinion and experience, should this person get herself or himself ready for this role? And the role that we are talking about here is a surgeon. So in simple word, it means that if somebody is aiming to become a surgeon, what should be the preparation of this person in terms of what are the various aspects? And we can use the context from the book.
Yeah, so thank you very much, Taranjit, for having me here. I'm not sure whether I'm the right person to discuss the weighty matters that you're raising through this book. However, I will do my best to try and answer some of these questions as I see it. So this is a very important question you're talking about. If you're a surgeon or you're going to be a surgeon, how do you prepare yourself in the light that we are not gods? How do we prepare ourselves to deal with the other humans who trust their lives to us? You know, when I was doing my medicine, I had a surgery professor. He was a bit of a humorous guy. I don't know whether this is his original. It might have been there a long time before him. But he used to say this quite often, that those doctors, those surgeons who don't have any complications, there are quite a few of them. You know, you will meet them in your practice, either as a patient or as a colleague, who will say, oh, my patients don't have any complications. Everything works very well with me, particularly with patients and also with the colleagues. And he used to say that if a surgeon or a doctor doesn't have complications, all his patients who develop complication have either gone somewhere else for treatment or he's lying. You know, so both of these can happen all the time. A lot of times, your complications end up going to somebody else. In fact, just today I saw a patient just a couple of hours ago, a significant complication that had happened as a result of a colleague's surgery, and I'm sure many of my colleagues who may be here or outside would have also seen a few of my patients who turned up with them, because oftentimes when patients develop complications, they don't trust you, they go and look for somebody else. Or if you say that you had perfect solutions, you're lying. So going back to Gawande's book, it starts off with him trying to write about complications. So you know, this is something that people don't want to talk about, like I said with that quote.
Mentions and he mentions in the book as well. Yeah.
So and then he says that, remember, he was just a final year resident, a final year PG, as we would call, And here he was trying to write something about complications of all places in a New Yorker magazine. He was not going to do that in a blog or something. So, so he was naturally worried, because whether it is in India or America, it's not a fashion to speak about your fallibility. That is the complications that you might face. And so he was worried what kind of a reception he might get, whether he'll get into trouble for writing this. So he goes to his professor of surgery, someone like Deepak, and tells him, boss, I'm planning to do this. What is your advice? Because he's worried that the medical establishment might, make him an outcast, a pariah. And the professor of surgery, the chair at Harvard, where he's doing his residency, encourages him to do this. That is something which is not very common. This is true in not just in medicine. You may be a lawyer, you might be an entrepreneur. You don't want to be labeled as a failure. If you admit that you have complications, that you are fallible, as you put it, it is for many people an admission that they are not good enough. But that is where the whole problem comes. We have to understand that as in life, in medicine as well, you'll end up with complications, and therefore be prepared for it, rather than hide it or sweep it behind the carpet. I'll just quote something from this book, that to much of the public, and certainly to lawyers and the media, medical error is fundamentally a problem of bad doctors. So everybody thinks that if you're a bad doctor, only then you will make errors. But that is not true. That is not true. All of us will make mistakes, and all of us will have complications, even when we haven't made mistakes that are evident to us. So I think the most important thing that we need to understand, if you're planning to be a surgeon, is to know that you will make mistakes, that you will keep a close track of what mistakes that might happen. And when you see one, try to redress it rather than sweep it under the carpet.
In fact, when you make mistakes, if you accept that you have made mistakes, it's only then that there's a possibility of learning from it and evolving through it, right? If you keep hiding it and putting it under the carpet, the possibility of learning and not making or repeating it in future is way much less. What do you think, Deepak, about this preparedness part?
I think like Kita said, it's easy to make mistakes, which is why we still call it a surgical practice. We're all practicing every day, right?
Yes.
If I was an airline pilot and I was flying something and I made the smallest mistake, I would die with the rest of the people that have trusted them.
The stakes are very high. The stakes are very high. Yeah.
But we survive, and people give us this immense trust and responsibility, put their lives in our hands, and we move a maxilla 3 millimeters and we feel like God. It's the stupidest thing ever. The thing that I tell my residents about making mistakes is that, and as Gawande, quoting him, the skill can be taught, tenacity cannot be taught. And that tenacity and grit is very important. And sometimes you don't, our residencies are 4 or 6 years long after dental college. And sometimes I tell them that 6 years is not enough for you to be a surgeon. You learn techniques and you learn how to do some things, and you may even know why you're doing those things. But, I'm about 15 years into my independent practice. I was first given a knife and asked to cut by Kishore Nayak in 1996. And the trust that, and of course, the patient didn't even know that I was a 4th year dental student or whatever at that point, right? So how do you pass that on? How do you train the next generation of the willing ones to make sure that that torch is carried on? When mistakes happen, you have to audit not only yourself, but your team. And one of the things I emphasize in our program is a de-emphasis of hierarchy. And I think that's a very important concept, because if I had co-pilots or a good air hostess or a technician, if I was a pilot, telling me that don't take off I haven't filled enough air in that tire, then I'm not going to take off. If I had a first year resident telling me, don't cut yet, I haven't checked labs on that patient, I should not be on a high horse, look at that first year trainee and go, what the heck, I should wait, and I should swallow my pride. And one of my chief residents, when I was an intern, told me that when I step into the training hospital, I should leave my ego in my car. And hopefully when I leave my hospital, you will leave the ego in the garage. So there's no ego at all.
Yes.
And there's a big factor in that. And that factor comes down to admission of guilt and admission of difficulty, admission of ignorance, admission of gullibility. And when mistakes do occur, sometimes medico-legally, my team, I have a team of lawyers in the hospital, risk management. And this is July. July is a month when residency starts in America. And so I have all these greenies that are walking around that have never done anything, and they have never been in a hospital setting before. And they're starting off fresh, and they take the wrong tooth out, they knock the tooth and crown next to it out when they're doing it, they're putting IVs in and they're missing it, and they're causing, all kinds of issues. And so it comes down to auditing the process. Why does something happen? Where does that go?
Yeah.
There's a concept of a Swiss cheese model.
Yes.
If you've seen Swiss cheese, it's got holes
the
in
holes,
it.
Yeah, it has the
Right.
holes in it.
If you stack up enough Swiss cheese slices, there'll be one small hole that connects everything from one end or to the other. So even when we have systems in place where checks and balances are taken care of, sometimes something goes right through. And it might be something that we did least expect. You may go in fully prepared for a trauma surgery. You know exactly what to do. You watched a thespian like, Gopal do it 100 times, and you know the principles of fixation, and you know the principles of anatomy there, and how your access should be, how your closure should be. 3 weeks later, you got a person with a pseudoaneurysm. Where did that happen? How did that happen? And things like that happen. So step back, audit, look at the system, learn from mistakes, do not have an ego, be open to admission of mistakes. And that the whole book, if you look at it, is Gawande's admission of humility, ignorance, gullibility, guilt, and lessons learned. So this is a Harvard trained surgeon who is a New Yorker writer. He's this book is 2 decades old. He's currently tapped to be the CEO and the chief health officer for Amazon Health. He's going to change the world with his approach, his thought process. The guy's a genius. And the first step into that genius was admission of, I don't know.
I don't know. Yeah, that's a phenomenal phrase, I don't know. I think we should respect the person who says that, I don't know. Yeah.
Correct.
But at the same time, in the book particularly, I felt that, of course, it was 20 years, so we don't know. But currently we have enough, like in your case, even in Gawande's case, his seniors were very supportive. They were very right role models, So don't you think that for our residents or our fresh postgrads, they must look for right role models? Because there are times when, in one of the chapters, like when good doctors go bad, he talks about 3 behavior patterns which the surgeons could have, throwing instruments in the OR, and some more behavior patterns which are unhealthy patterns. So now if you see your guide or your seniors doing this, there's a very high possibility that you'll pick up those patterns in a very subconscious way, and that can be, so in a way, if our freshers would look for right role models, or at least they would know that, this is the good and this is something that I would like to follow. I think that would also be helpful. What do you think? The role of role models?
The opposite is true as well. You learn some things not to do and some ways not to be. And fortunately for me, this room is filled with my mentors. Dr. Dabir's there, Gopal, Dr. Bonanthaya.
Same with me.
Yeah, I mean, these are amazing people that have the shoulders of these giants that we stand on. And to the mentees in the room, I mean, it's not about finding a role model or anything like that. Ekalavya didn't have a role model. He learned on the go, right? So he figured out that I'm not going to get an opportunity, but I'm going to find one. And so it's mentorship is very tricky, especially with the new generation. And I am sure Kita can attest to that.
Yeah.
What would you say, Kita?
So if you just remember what Deepak said earlier on, he said that we should not have a hierarchical system in this kind of a environment, but
yes.
we have a very rigidly hierarchical system,
Yes.
And much to my surprise, a few years ago, this thing happened in my OR. So 2 residents were at loggerheads for whatever reasons, and this was affecting the work. And so I was chatting with them as I operated, and I asked this guy, why are you 2 guys fighting? So, sorry, I asked this girl, why are you 2 guys fighting? So she says to me, I'm a 2nd year postgraduate and he's a 1st year postgraduate. He doesn't call me madam.
Oh,
right. So I asked.
And here I'm calling you Kita.
Yeah. So you're sacrilege. So I asked the 1st year guy. So why are you not calling her madam then? So he says, I may be 1st year, but I've been in practice for 15 years. I'm much older than her. Why should I call her madam? So and then I realized that the practice, believe me, this was not the practice when I was training. We called our teachers sir, but we didn't call our co-residents as sir or madam. But this is something that has become now the day somebody joins in, their instructor. So we have a terribly hierarchical system, and I don't think that is good, because what tends to happen with that is that you are scared to point out mistakes. It has happened to me a number of times, and then somebody is helping me out and I do something which I shouldn't have, and then they point that out to me later on. Oh, I saw this, and then I ask them, why didn't you tell me? And they don't open their mouth. So the thing is fear, and that is something which is extremely counterproductive. Because like Deepak was saying, if I as a senior was pulling out the wrong tooth, before I luxate it, if somebody says this is not the right one, whether it's a nurse or an assistant, I would immediately change. Going back to the matter of fallibility, Taranjit, I just want to take that a little more deeper from the book.
Yes.
So I said to you that all of us make mistakes, and let me quote Gawande. He says, human beings err, but they err frequently and in predictable, patterned ways. So it's not just bad doctors who make mistakes. All of us will err frequently as well as in a predictable way. And systems that do not adjust for these realities can end up exacerbating rather than eliminating error. Take a simple example of somebody doing too many surgeries in a day. Some people are very proud that they can do 6 or 8 or 9 surgeries, but what will be the quality of your work, however good you are, towards the end of the day when you're doing your 8th or 9th surgery? That is when you're likely to make mistakes. So it is important for us to realize that problems are happening. I just give you an example with statistics. These are very, very telling, again, from the book. This is for something for everybody to ponder, just to see how, if you are aware that there are problems and you find out a solution for that, how dramatically the quality can change. I'll just read this out. In the 1940s, there was 1 death resulting from anesthesia in every 2,500 operations. So for every 2,500 operation in the US, 1 person used to die due to the anesthesia. okay, in the 1940s. And 20 years later, between the 1960 to 1980s, it stabilized at 1 in every 10,000. So 1 in 2,500 became 1 in 10,000 in about 20 years, various safety factors. But there were people who were still not happy with this, you know. And most important thing, if you look at these anesthesia deaths, the ones that were preventable, the most common one was either the oxygen running out or you are doing an intubation into the esophagus. And they say you will be surprised how even the most experienced anesthesiologists can sometimes do this esophageal intubation and not pick it up for whatever reasons. So what was the change that came after the 80s? There came the monitors, particularly what is called as the end-tidal carbon dioxide monitor, you know, the EtCO2. And the EtCO2 is something that will tell you in the instant that whether your tube is in or whether it has been accidentally extubated. The curve goes flat. And with the introduction of these monitors that looked at oxygen saturation and end-tidal carbon dioxide, you know what happened to the death rate? Remember, it was 1 in 10,000, right, in the 1980s. And when these things came on, in a decade after these end-tidal carbon dioxide monitors came in, the overall death rate dropped to just then 1 in more than 200,000. Okay, less than 1/20th. So for every 20 patients that were dying before these two simple monitors were there, now only 1 was dying. Just look at the amazing transformation that happened simply because people realized that the safety features during anesthesia was not good enough. You had well experienced anesthesiologists, but the margin of error was so low, you know. But now you just look at the monitor, you can immediately know something is wrong when you have intubated or while you're doing the surgery. And these mishaps that occur as a result of hypoxia or the tube not being in place, which is the most easily avoidable one, has virtually been eliminated, provided, of course, you're using these monitors and they are in shape. You know, I will tell you a story about one of the deaths that occurred with one of our partner hospitals. I work with an organization called Smile Train, and Smile Train sponsors free cleft lip and palate surgeries around the world through partner hospitals. So whenever there is a sentinel event, I mean, when there is a death, for example, this has to be reported to the Smile Train board, and then they go through your records with a tooth comb and trying to find out what might have gone wrong. The aim of this is not to punish the partner. The aim of this is to learn lessons so that anything that could have been avoided can be picked up, and then that lesson passed on to all the 1,000-odd partners around the world, saying, look here, if you are using isolite P for children, it can cause hyponatremia. Don't use isolite P. This is one of the advices that came in. But I go to this story. So there was this death that was being investigated by the Smile Train Medical Advisory Board, and they found out, don't ask me how, that there was this hospital where the death occurred. The monitors were not working. You know, we talked about the oxygen saturation, the EtCO2. So what they had done was, just to keep everybody happy, I don't know who did it, whether it was the hospital admin or whoever else, had kept the monitor showing 100% all the time, you know, SpO2. So if you looked at the monitor, it will show 100%. It was set there. And if you believe that, you thought that there was 100% oxygen going on. So you can even cheat and cause deaths. It does happen. But having said that, most people would today rely on these monitors, and things drop down there. They would look for a reason and then take appropriate action. Enough experience is there. The fallibility comes in because of the circumstances. Like I said, you err predictably. For example, I just give an example from my own situation. When we do a cleft palate surgery, we put in this mouth gag, which goes and sits over the endotracheal tube. And when we release this mouth gag, if we do it a little harshly, without, supposing I'm in a hurry to run away somewhere, or I had to answer a call or whatever, I pull the gag out quickly, there is a possibility that the lower end of the tube comes out of the trachea. You can't see it because on the top end, the tube is still taped nicely to the lid. So the tube has come out. The only way you can know it at the instant is to see what is happening to the EtCO2 curve. And I find year in after year, even today, I was casually asking one of my residents, which would be the more, they have 2 monitors, there are 6 graphs going on up and down. I asked them, how will you know if there is an accidental extubation? Every single time they'll tell me that the SpO2 will fall, but that's not true. It takes a while before the SpO2 falls after you've extubated. The right thing is the EtCO2. So if you look at the EtCO2 monitor, which came in the late 80s, it has already saved hundreds of thousands of lives around the world. So what is the bottom line? The bottom line is to try and increase the use of technology, which helps us deliver better care. So this is an issue I think you're raising later, whether technology is going to make us obsolete. We'll discuss that later. But it's important to know that we can improve quality if we understand that mistakes happen.
Deepak, any comments on that?
No, I think that was well stated. Technology is a partner, but remember, your eyes don't know, what your brain doesn't know.
Exactly. I think we'll come to that point towards the later part of this.
Right.
Dabir sir, do you have any comments on this? And then we'll open it for everybody else. Would you like to share your experience?
Good evening.
Good evening, sir.
Deepak,
hello, sir.
Yeah,
hello, sir.
No, I have in this basis, I just remember one small thing about monitor. In one hospital, we realized the patient had, the anesthetic had gone for nature's call. And the old style is you always keep looking, keep an eye on the chest and the monitor. And I saw that the chest wasn't moving.
Right.
And the monitor had gone blank. So I immediately made, we got somebody and the tube was disconnected. So I was quite surprised. I said, how has the monitor gone off? So I said the battery backup of the monitor had died. See, the battery backup was not in order. So when they were running the monitor only on direct electric supply, and the supply got disconnected. So ultimately, I think all of us have to rely on our old reflexes, one eye on the chest and things like that.
Sure, absolutely. Yeah.
So could we have a conversation from the attendees? Anybody would like to share?
You can raise hands. Yeah. You can raise hand.
I don't think
so that we know there is. Yeah.
Don't have
they can
a
go
raise
to
hand.
more.
Yeah,
raise hand.
Just unmute themselves.
Yeah.
Anybody would like to say anything?
I have raised my hand.
You have?
Yeah. Taranjit, while we are waiting for them to raise hand, I'll give you another instance of how a mistake can give rise to very, very classical example of what happened with an airline crash. I don't know if you remember, there was this Lufthansa subsidiary, the low-cost airlines of Lufthansa, whatever it was called. This one went and crashed into the Alps and everybody died. And they then found out that the co-pilot was a psychiatric patient whose history was, of medication, etc., was not carefully considered by the airline management, and they continued to roster him. But what happened? So that was a mistake at the first level. So oftentimes when there is a disaster, a number of mistakes add up. It's not just one.
That's what Swiss cheese model he was talking about, right?
So number of layered mistakes happen. So there was this airline management that had ignored the warnings about this guy being a psychiatric patient. They had not evaluated him well. And what happened on that day when he was suicidal was the captain, the boss, this guy was the co-pilot, the captain went out to take the nature's call, like Dabir sir said, and this guy locked the cockpit from inside, wouldn't allow the captain to come back. So the captain was stuck with the passengers and he was all alone, and he went and crashed and everybody died. What was the corrective measure that they've brought in now? Oftentimes when you're on a flight, you will see one of the air hostesses going inside into the cockpit and staying there as one of the pilots come out. So then they made a rule that a co-pilot or a pilot cannot be alone if one of them goes out, that there has to be another airline employee there so that this kind of a disaster will not happen. It's a very, very simple thing. He locked from inside and he wouldn't allow the captain to come in. And the aircraft went crashing and some hundreds of children died. So sometimes after the horse runs away, you use the bolt, but it might prevent other horses from running away. Somebody's raised a hand, I think. No.
No, that does bring up a good point about checklists, and our man has written a book on Checklist Manifesto, and in Checklist Manifesto he talks about how even the most elite of athletes have a coach, and if you're Roger Federer or you're Djokovic or you're Tiger Woods or you name it, everybody has a coach. Despite the fact that you're world's #1, you're still coached by somebody. Surgeons don't have coaches, You suggest to Ashok Dabir that he's going to have a coach, Ashok Dabir might take the coach, but at every point, somebody comes to me and say, let me teach you how to do surgery. I'm going to tell them, let me teach you how to do surgery, right? And that's our natural instinct. And so what we have done, is what Kita said, is, it's ubiquitous in the United States, which I'm sure is happening in India. I just don't know. Is the concept of a timeout and a checklist before every procedure, whether it's a local anesthesia for a single implant or a head and neck procedure or a cleft lip and palate. In fact, it goes to a level of ridiculousness sometimes. So when I'm at Children's Hospital, for instance, I have to introduce myself before every case, even if it is the 6th case of the day. I introduce myself and the patient's name, age, weight, date of birth, medical record number, allergies, procedure we're going to do, identify if it's teeth, they want every tooth called out, biopsies, they want to know if the biopsy will need to be sent in formalin fixed or fresh, if I need frozen sections. All of these things have to be said ahead of the case for every single case. When I do longer, bigger cases, if I'm doing a bigger procedure, I actually write down the steps on the board in the operating room. So everything from, once we intubate, I'm going to place maxillomandibular fixation. Then I'm going to make my skin incisions. I'm going to put my total joint prosthesis. Then I'm going to go into the mouth. I'll do my Le Fort. The last thing I'll do is my genioplasty, whatever. Every step is written down, and I ask the scrub or the circulating nurse to wipe off every step that we have done so we don't miss anything. And that helps quite a bit. And one of the things in oral maxillofacial surgery timeouts or checklist that has now become a standard practice, adding or removing a throat pack. We've and some of my residents we've had never events, things that should never happen. A patient was placed in tight maxillomandibular fixation with a throat pack in and was extubated, and almost disastrous scenarios. So for some people that forget, I know that, what I do routinely is I put as soon as we scrub in and the patient's prepped and draped and the throat pack goes in, I take an artery clip and I clip it to the resident's scrub. And I say, their scrub top, and I say, take it out when the throat pack comes out. If you still have an artery clip on, it means the throat pack's still in. So that is one more
interesting reminder.
It's a reminder. It's a checklist.
It's a reminder. It's a very good reminder.
And these things, just like what Kita said, the pilot shutting himself off and that changing protocols. When we leave a throat pack in, that changed our protocol. And every step forward from there, we have the standard procedure that we put a hemoclip on somebody's or a hemostat on somebody's scrub top, and that's how we know the throat pack needs to be taken out. It might sound silly, but it's very important. I don't want to lose a patient,
Absolutely.
Deepak, I have a question for you. I mean, we were talking, there was a small glimpse on technology, the mobile technology, which is so ubiquitous now, and it's everywhere. It's there in our ORs. our anesthetists. In the book also it's mentioned that the catastrophes do not occur in the beginning, because in the time of intubation, there's a lot of attention given. It's in the middle of the procedure, when the patient is maintained, that is when most of the anesthetic complications occur. But you will notice that the phone, the mobile phone, which is there, instead of focusing on the patient or on the monitor, everybody is more focused on their mobile phones with, something going on. And then even the surgeons who are operating, I don't mean to sound judgmental, but this is something that I'm seeing from so many places. Mobiles are always there in the background. Some people are even working with their Bluetooth in the ear, How do you think, what kind of, don't you think this is something that leads to, so what is it in US? How do you guys, is it allowed, all these things?
We have the same problem. I have,
when thank God, we are not, we are facing similar situations.
Yeah, we, for head and neck cases, I think the attention, so when in Gawande's case, the middle of the case when things happen is a general surgery problem. You've got a change in the homeostasis, open belly, sudden bleeding. A distracted anesthesiologist is a disaster. In our cases, we typically have younger, healthier patients with airway issues. So the attention is at intubation, extubation. And in the middle, of course, if you're doing a head and neck case or something, it makes a difference. But generally, that's not the issue. But the issue with the phones is there. We have the same problem. And I call my residents screenagers. They are digital natives. I made rounds this morning, and my junior most resident, when you're kind of engaging them in conversations, how did this patient do? What is third spacing? Okay, this person's all swollen up, septic. What is third spacing? So first person that I'm asking that question to has no idea, but the person standing 2 people back is already on their phone Googling what is third spacing, right? So the culture has changed a lot. In fact, we are working with the American Board of Surgeons to create a module called SCORE, which is surgical curriculum. And SCORE will come out next year. And it is 5-minute blips on just about everything. So if you're going to scrub in with Dr. Bonanthaya on an alveolar cleft graft, and you want to watch a 1-minute video on how to take a hip graft on, and a 1-minute video right before he starts, he's probably outside of the sink scrubbing in. You can look at pertinent anatomy, you can see a picture, you will watch a quick video, you can scroll through things, and then there will be selected reference reading that you can click a link and go further on, which you probably do at the end of the day. But the way that learners have changed, phones are here to stay. It's not evil. It's sometimes a distraction, but so are many other things, and there's no point fighting it. I have given up on 2 things. One is the fact that phones are not going away from my residents' hands, and the other is that my male residents don't think that shaving and coming to work is a good idea. They all have to have a stubble, which makes them look like homeless people, but they think it's cool. The look of a doctor, as they call it, that's changing.
Cool. That's nice to know. So do we have a conversation? Do we have any comments or anything from our attendees, or should we move on to the next question, because we are already 40 minutes into this? I can't see anything.
Can I just quickly say something before you move on, with your permission?
Yes, please do. Yes, please.
Taranji? So this is for the residents. There is a question. Okay, let's look at this question there is one from Yajas Kumar. Okay, I'll read that out. I wanted your opinion regarding finding the line between ethical treatment planning and academic interest. How do we decide whether what we are pursuing is justified or helping us or helping the patient? I think it's a fabulous question.
Fantastic question.
This is something. Do you want to leave it for later? Are you raising this issue later?
Let's do it now, because
okay. So this is a very, very important question. And Atul Gawande also very clearly explains this. He says this is about the trainee doing the procedure. That's something we can talk about as the ethics here. So in a situation, a very similar example I'm giving. When you come into a teaching hospital, the consulting, the professor decides whether he will himself operate the case or one of his junior qualified colleagues will operate that, or one of his residents will do part of the procedure under supervision, and so on and so forth. So you have a number of different ways that this procedure may be carried out by different people. However, for all legal and practical purposes, to the patient and to the outside world, we are saying that it's the professor who's responsible, or the consultant that is responsible. So ethically here, if once you say that the professor is doing the procedure, you have to do it yourself. So Atul brings out this point very, very clearly. So he says, well, I don't know how to deal with this if it is me who is going to do it. However, the patient is admitted under the consulting. It is the impression that the consulting is going to do it, but I know that I'm going to do most of the procedure. So what do I do when I go and talk to the patient? I say, my name is so-and-so, I'm a surgical resident, and I say, I will be assisting the attending in this procedure, okay? So it is not the real truth, he says, because he's not assisting, he's actually doing it, supervised by the professor, but that is not something that is very clearly enunciated, you know, that is something he points out. And what would happen if I, as the professor today, go and say, you know, my fellow Mr. Biswas is just joined here and he's going to do the cleft lip. They will say, doctor, please don't allow him to do it. So if this continues, how do we train? So this is exactly what you're talking about, ethical treatment versus academic interest. I think there has got to be a balance. End of the day, academic interests are very important. For example, I'm raising the issue of training here. If you don't train the next generation, you are going nowhere. So somebody has got to. However, the balance here would be ultimately whatever does happen with that case, it is the attending, the consultant, or the professor who has to take the responsibility. That he can't just go away and start watching the stock market monitor in the surgeon's room and allow somebody to operate. Then that's when mishaps happen. He's got to be around and he's got to make all the decisions. So in a way, Atul says, when I do the surgery, it's the professor who's saying, cut here, stitch here, take so much of the intestine away, do your anastomosis like this. So end of the day, the decisions are being made by him, and the decision whether this guy is capable of doing this procedure is also made by the attending. So that is where the balance comes in. So academic interest is important. Obviously, patient health and quality of care is also important, but you can't ignore one for the other. How do you get this balance? That is something which we are all grappling with. And occasionally, I'll tell you, I have regretted this because the kind of work that I do, sometimes the problems come up many years later. For example, I operate on a cleft palate at 9 months of age. At 5 years of age, I see the child not able to speak well. And then I find out that the palate has not been repaired well. And then I find out that sometimes it is me, but many times these are the junior residents who have done, but I can't blame them. You know, if I allow to do them that procedure, I have to make sure that the results are at par. They need not be excellent, but at par. So I hope I'm making that point clear. Yajis,
does that answer your question? You can
I interpreted his question slightly differently. And there's a concept called MRB, maximum resident or maximum trainee benefit. And I'll present a scenario. So for instance, if I had a patient that came in with a small ameloblastoma in the mandible, a small one, you know, one tooth and around it, I could make an argument that, you know, the most conservative but effective approach for this would be a mandibulectomy, not a segmental mandibulectomy, but a marginal mandibulectomy. Take the tooth out, get the enough margins, remove the tumor, and save the inferior border. I might have a trainee that has never done a segmental mandibulectomy. And that trainee might come up to me and say, show me 5 papers that say that, you know, Dr. Bob Odd says that marginal mandibulectomies for ameloblastoma have a 15% increased chance in recurrence. and you should do a segmental mandibulectomy. And in fact, not only should we do a segmental mandibulectomy, we should also take a posterior iliac crest bone graft and graft him immediately. And I would say, well, that's a good idea. In fact, that would benefit both you who have never done this procedure, and also
probably it's your thesis topic. Probably it's your thesis topic.
Well, yeah, you know, and whatever, you can make 100 arguments to. That's where the ethical issue comes to play. In our unit, maximum resident benefit is a banned term. You're not allowed to think of you as the beneficiary here. You can only think of the patient. So the one aspect of the question in my mind is there is no choice there. There's only one thing to do, and the right thing to do is do what is right for the patient. And it's not about what is right for you. You may get a chance later on in life to do the exact same thing, and you may graduate your program, your training program, without ever doing one. But that's just a snapshot in time. You need to know basic principles. You'll figure it out eventually. Just because you did 15 of something doesn't make you a master at it, and just because you have never done one doesn't make you completely incapable of doing it either. One of the measurements that we have at the end of training is entrustment. And that's what Dr. Krishnamurthy was saying about, can I trust a junior resident or a senior resident or a fellow to do this? And ironically, Gawande said that when his child had a problem, he did not want the resident in the room. I can tell you, I've had 2 children, and both times the second year OB resident did the C-section. And in fact, I was at the head of the bed, and they asked me if I'd like to do an aesthetic closure of my wife's belly, which I politely declined. And, you know, so this whole concept of entrustment is tricky. There are some residents that have intrinsically fantastic skill, make good judgment, and decide that, you know, with the exposure I got, some people only need 1 or 2 procedures to do something really well. Others, after 20 of the same, are not good enough, and should you be offering them the 21st? The other aspect of this is this ethical treatment planning versus academic interest is, say, innovation. And a good example of that is I do a lot of total joint replacements. And a few months ago, I saw a colleague of mine. Typically, when I do a joint replacement, I have 2 incisions, one preauricular and one submandibular. I place the ramus unit through the submandibular incision, and I use the fossa unit through the preauricular incision. And I watched a colleague of mine present an abstract where he has been doing it through only 1 incision. And he's innovating. He is doing something that has not been done before. And so he makes a preauricular incision, and he's able to sneak the ramus unit through there, and using trocar incisions, he can put screws in perpendicular to the mandible, but he stretches the heck out of that facial nerve when he does that. And so I question, okay, well, I can get in a safe plane, and I can cut something, and I can avoid the facial nerve, and all right, I'm getting a second incision, but I can get to where I need to by making that second incision. That's innovation versus what is ethical, right? Am I going to stretch out the nerve and innovate and avoid 1 more incision on the face? Or am I going to continue doing things contemporaneously or what is considered conventional? If you don't attempt some things in an academic interest, with an academic interest in mind, you will never innovate. There might be, you know, there might be issues with ethics there. If I said, you know, all of my alveolar clefts will now be treated with bone morphogenic protein, and I'm not going to take out a single kid's hip hereafter, somebody can come up and say, well, this is not studied in humans, and we know that it can cause tumors, and there are some reports that say this and that. And if I step back and said, well, am I doing something unethical, or do I come up with 200 cases over the next 5 years and present my study saying 0 complications, did not need a second morbid site? So where is the ethics and where is the innovation in that? So one step leads to another. So those are the 2 ways that I actually interpreted Dr. Kumar's question slightly differently from what Dr. Bonanthaya said.
So Deepak, what I'm trying to understand is that this pressure of publications can lead to some sort of ethically, gray areas of treatment planning. I mean, you think something of that is happening?
Yeah,
sometimes when we want to publish things, and for the sake of publishing, we are doing, we have that thing going on in our head that we got to show that we are doing this. We may be doing
the gray area is the problem. It's black and white.
There is a gray area. The pressure of publishing is very, very great. Yeah. So we move on to the next question because we have quite a bit of topics to discuss, and I don't know where is this disturbance coming from. Can I request everybody to please stay mute because it's very, very disturbing.
It is Salwa.
Salwa. Please mute yourself, Salwa. Yes. Yeah. Okay. So I think we'll go to the next question. Now, I want to ask, in spite of all the care and caution that we take, complications do happen in everyday surgical medical practice. What are the reasons for these complications and what should be the right approach to handle? I think reasons, more or less, we have already discussed. The approaches is something that is very well discussed by Atul in his chapter, I think, Computer and Hernia Factory, and when good doctors make mistakes. I think he has discussed some of the reasons very well. Should we start with you, Kita?
Okay, complications does happen. Yeah. It does happen. Okay, now I will divide these into Jasmine. Could you please mute yourself, Jasmine?
So sorry.
No problems. Thank you.
No problem.
So there are complications which are minor, which are not life-threatening. These, let's not discuss that, but let's discuss complications which can be serious and can be life-threatening. I just gave you an example of how death rates came down. So it can happen in all kinds of situations. And more you do a particular kind of work, more complications you end up having. I hope you remember Dr. B.R. Patil, who was a fabulous cancer surgeon in Hubli. And he used to tell me when he did necks at SDN. So he used to tell me, I have experienced, he had done thousands of neck dissections by then. And he told me one day that I've experienced all the complications that are listed in head and neck surgical textbook, plus some more, which are not discussed. So therefore, complications happen because we have made a mistake or we still don't know. So that is a very important thing that we need to remember. We don't know everything, and therefore there is always a knowledge gap which leads to some of these complications. And sometimes it may be simple things like not being aware of something, not following the protocols, not having the proper equipment with you. I will just, before I go on to my own examples, I will just list out the factors that he has given why things go wrong and you get complications. It can be a lack of standardized protocol. It may be the surgeon's inexperience. Okay, so you are learning to do surgery and you make a mistake. It may be the hospital's inexperience. It may be inadequately designed technology or techniques. You don't have the proper instrumentation. There's thin staffing, so you don't have people to help you who understand what is to be done. There's poor teamwork. You're handing over patients and you're not giving enough data to your
communication.
Communication. The time of the day, if it's early in the morning and you've already been working throughout the day, the effects of managed care and so on and so forth. So there are a number of reasons why complications occur. I will just give you an example, just to a personal example. Maybe you were one of my postgraduates then. This was the year 2000, and on a Sunday morning when I was on call, I got this patient who came in, very severe Ludwig's angina, very severe. He had inspiratory stridor, okay, and unfortunately, a local hospital in Hubli had kept him admitted for the previous 7 days, giving him IV antibiotics, 7 days of IV antibiotics, as this neck blew up and blew up. And on a Sunday morning, when they heard this noisy stridor, they called us and said, can you please do this drainage of this dental abscess? 7 days of IV antibiotics, sitting on it. And here he is now, his larynx is closing. So he came in, and we kept him in a sitting up position. His SpO2 was something like 85 or 88. And I decided to do a tracheostomy followed by the drainage, if required, if we could not intubate him. So it was a Sunday, and I called out for the best anesthetist that we had in town. You know his name, I won't mention it. And when we called up, he was not at home. So the second best man came in. He was not so very best. So when we tried to intubate this guy, it was not possible. Okay, so he said, "Agadillari madakagala." So he said, "I can't do it." So then I said, "We'll do a tracheostomy." And then I put this patient on the table flat again and extended his neck or whatever. And the moment I was about to put the knife, he arrested. Okay. And after that, it was a mess. I lost that patient. Okay. So I can very easily here blame. I've already been a little sarcastic about the hospital that kept him there for 1 week, giving him IV antibiotics. If you ask, so if I'm the kind of person who always thinks that I am always right, it's always the others who are making the mistakes, you can have that attitude to your complications. I didn't do it, somebody else did it. I can say, look at that guy. He admitted him for a week and now he's discharging, and that guy killed him. But that's not true. Though what he had done was not correct, the mistake I had made was to put the patient flat. You know, he was already, his airway was already closing. You know, we knew that he had significant inspiratory stridor, he had hypoxia, and then I put him flat, supine, and made whatever little narrow airway there to close, and he became hypoxic and arrested. So what I learned from that, I did not recognize that at that point of time. And then I went around discussing this problem. Believe me, it's one of the worst things that can happen to you when you lose a patient. You helplessly, and you think you have not done the right thing. And I wasn't sure even at that time what was the mistake. And I was talking to a very famous max fax surgeon who's also an ENT in the US. His name is Eric Dirks. And Eric told me the mistake was that you should not have put him down. You should have done the tracheostomy with the patient sitting up. You know, it's a simple thing. Probably I could have saved the life of this patient if instead of putting the patient flat, I had done this tracheostomy with the patient sitting up, where he was still able to oxygenate himself reasonably well. Okay, so it took me a long time to realize that. And this is a kind of thing that I would then pass on to, you know, my trainees and so on. And therefore, complications do occur. The bottom line is very simple. All of us will do complications. We may not be able to avoid them when it happens, but the most important thing is to accept your responsibility in it, number one, and therefore understand why it happened. Sometimes you will still not know, but in this case, I clearly know what happened. And once you understand that, don't repeat that mistake. It's simple as that.
Deepak, he talks about, thank you so much, Kita. I think your honesty and your, you know, confessions, the open confessions are really brave, and we really appreciate what you have shared with us. In the book also, Atul talks about when complications happen, how do organizations or systems, deal with them? And 3 ways, I think he describes 3 ways. The first thing is M&M meetings, which are absolutely missing in India. The culture of M&M, which is mortality and morbidity meeting. We don't have that, you know. And that is something that I think that we should try and bring in our own way. India is a country where we don't have external factors which support our health system. So I think as health professionals, with our awareness and motivation, we can try and do good work in our own way. And that's what we are doing in my institute. But I think through this conversation, more and more people can do that. M&M meetings are very, very important, you know. And the other technique which America uses is litigation. So, but then in Gawande's book, he very clearly states that litigations are not helping. You know, just because you have very strong law enforcement agencies after your neck will not reduce complications. Then there's a problem with M&M meetings also, which I think somewhere he says that discussing M&M meeting and what better you could have done, you know, does not, you are still pinpointing at a person. Whereas what really needs to be looked upon is that basically when complications happen, it's the system which is the faulty system. And one has to look at complication as more as a process than a pinpoint situation or a pinpoint event. It's a process, and the process happens in a system. So eventually we all have to look forward or look towards creating robust systems, right? Deepak, would you like to say something here?
Right. So we have routine M&Ms, this morbidity mortality conferences. We have it for the Department of Surgery as a whole, and then for the Division of Oral Maxillofacial Surgery monthly. And it's a good process. And as Gawande says, you know, my job as the chief of oral maxillofacial surgery is to step back. I don't need to know who did what. Yes. In fact, it's just like how he presented it. The chief resident that was involved in the case presents. It may be the intern's mistake. It may be a decision-making error from the attending consultant. But you know, I don't need to know who made the mistake. And it always is the consultant or the attending surgeon that steps up and explains the process of error. At the end of the day, I have one question. Okay, how do we prevent this from happening next? And that's the only thing that we need to know. Yeah. That is just a systemic way of tackling with mistakes. That's not necessarily the only way of tackling with mistakes. The best way of tackling with mistakes, especially if you are a young person in a single practice that covers trauma multiple places, is first start with logging your cases. If you don't have a system of logging your own cases, you're really not doing yourself any favors. Second, start with auditing that log. And that log means to say, how many mandible fractures did I do in the month of June? How many of them have a malocclusion? How many of them have permanent numbness? How many of them have hardware failure? It's an internal audit, and that internal audit will be extremely beneficial. And my point being,
I love this point. I think my point is a wonderful point. I think anybody can do this. Yeah,
exactly.
Something you don't need somebody else to tell you to do this. This you can do it yourself. Yeah.
Yeah, you don't need a large organizational system to have morbidity, mortality conferences. You can have it with yourselves. Kind of weird when you talk to yourself, but you know, regardless, you can with yourself. I do want to bring up one more reason for complications, and this I had a senior resident that recently went through a major life event, going through a separation of their marriage and a divorce. And I noticed that as that person was going through that life event, their performance was distracted and had changed. I've had a boss that taught me how to do orthognathic surgery that was also incidentally going through a divorce. And that was one of the hardest years in my training. That person was always angry and upset. And so these external factors, regardless of what your personal, you know, challenge might be, can also spill over into your professional life. Now, my work is my happy place. So I actually think of my work as my work-life balance, you know, so it's okay, you can claim that I don't have a life outside of work, but regardless, my happiness is in my going to work and dealing with the little issues there and taking care of patients and teaching residents. Now, a lot of people can always, and this is the the counsel that I gave my trainee who was going through a hard time was try to find a refuge somewhere else. And that might be your mission, your work, your service. We're all servants. We are here not to serve ourselves, but to serve a person who's seeking our service. So have that mentality. And to the young folks in the audience, this whole concept of work-life balance, you signed that away the moment you signed up for this job. You better find balance in your work.
Yes.
And make that, and yes, you can take a break. You can go see the mountains and you can swim in the oceans and walk with the elephants or do whatever else weird stuff you want to do.
Have a couple of beers? You forgot
have a couple of beers. Yeah. That's a part of work too, as a culture, when Kita and I, we're all in the same unit, and when we had a major complication, it always ended up at Bangalore Club having a beer. And that's just how we decompressed after a real hard day. And that's part of work as well. So this emotional well-being is a piece of the surgeon that you need to really, really watch out for.
I love the IOMS, physician wellness series, which you have. It's a beautiful series, and this emphasizes the points which you are mentioning now. Yeah.
Right, and in fact, there's a small organization that I'm the secretary of called the American College of Oral Maxillofacial Surgeons, and ACOMS does small lifestyle courses. So you take 30 people and you pick an activity, say you like bourbon tasting. So you go on a bourbon tasting tour, but there are educational events in between bourbon tastings. Often by the end of the day, there's only bourbon left, no education. But it's a small group that is brought together, and we deliberately pick the attendees from different parts of the country, people who have different types of practices and things are part of networking. So these lifestyle courses where you decompress and yet learn is a good way to kind of promote these well-being,
We must take all these pointers for our association. Don't you think so? It would be such a happy place to be. Dabir sir, what are your inputs on this?
No, not really. Excellent. These are all good activities. Agreed. But like my boss, Dr. Dudani, my teacher used to say about what Kitta and Deepak said in treating patients is, like he used to always say, if this patient was like he was your father, mother, brother, or sister, what would you do? The best interest of the patient is always most important. So whether you're training your students, whether you're treating a poor patient, the best, you have to do your best. There is no substitute.
There is no excuse to a complication that we cause. No excuse to our mistakes. Do we have any questions before we move on to the next part? Because
somebody on the chat.
Does anybody has a question? Any question on the chat?
Or there is one from Arjun Shanai. I'll read that out, Saranjit.
Yes.
Arjun Shanai is asking or saying, let's see, a study also found a surge in complications among surgeons within a few weeks of attending surgical conference. This is called as the conference surgery. The survey showed a small percentage of surgeons sometimes blindly replicate results using new modifications or techniques.
Yeah.
That's a good point that Arjun's making.
Yeah. Thank you, Arjun, for this input. So should we move on to the next one? Okay. So the next question to our panelists is, when you witness a complication created by your fellow colleague, I mean, this aspect is when good doctors go mad, go bad. This particular question is based on this essay. It is like my favorite essay. When you witness a complication created by your fellow colleague, how would you or your institute or your organization handle this situation? How do you bring this out? Do you put it under the carpet because somebody else is doing and you look it the other way? Or is there any better way of dealing with it?
I've had a personal experience with this once or twice. I had a co-resident of mine that got addicted to medications we were storing in the office.
Okay.
She was a very talented person. She was in medical school at the time that we found out about the problem. We realized that drugs were disappearing from our drug box, and we just thought it was an auditing issue. And slowly but surely, it came to light that this particular person was using these drugs and stealing them. And it required an intervention. It required stepping up and saving her from the peril. The intervention worked. She actually took a year off, went to rehab, came back, and now is a successful practicing maxillofacial surgeon. Had several children since then, and that's one of the instances where you actually confront them right away, and that's a no negotiation. There's no compromise, because there's no winner by trying to sweep that under the rug. There is nobody wins in that scenario. You just need to take that bull by the horn and take it to task. The second issue that I've had was a little bit more complex. It was actually a senior mentor of mine that was becoming really difficult for him to both operate and remember things. And this was like a person that we could not trust patients with their, in the a quickly declining cognizance, and showed no interest or signs of slowing down. In fact,
Or
was
retiring.
was filling the schedule and was moving forward. And so it wasn't particularly one mistake that led to actions, but a series of events where there were, simple tasks that were becoming difficult to perform, including just giving local anesthesia was difficult. And things like that got to a point where, so what we ended up doing was in a large institution, you can seek help. So you can reach out to, there's a committee for staff well-being, and we found out that there's a test that he can take that can prove that if he's having any kind of cognizance decline or otherwise. And so there's a policy in the institution. If you're an operating surgeon and if you're above a certain age, you need to pass that test every year, which we didn't know about until we had a problem. So sometimes these things are put into the system, but we just don't know that there's an issue. So we explored that and we said, oh, whoa, Dr. So-and-so, you are such and such old. You need to now start taking that test. And poor man could not survive that test. It was it's not like playing Sudoku. It's a little harder. And so it was difficult for him to pass. And that gave him a self-realization that this is not for me to continue to do. So then he sought a different approach. He wanted to continue to work, but did not want to operate. So then we have kind of parked that person into the orofacial pain, medical management issues, and oral medicine issues, and things like that. And we've kind of, it's good to do that, but no physical skills required. And then at some point that became difficult, and fortunately he had self-realization and the wisdom to stop and move on. Has a great quality of life now. I meet him very often, and is happy that he quit when he could. But mistakes can happen when people at that level, individual handicaps, we have to be aware. The problem with surgeons is that we have this high horse that we ride on. We are the best amongst people that we know. And we know that, and we have a certain cocky attitude about that. And so how can I fail is the problem. And that is the issue. We have to get around that. And when I make a mistake, my team is empowered to tell me, you made that wrong. That was not what we needed to do. And surround yourself with people smarter than yourself and empower your team to bring up mistakes as it happens, as opposed to retrospect. Retrospectroscopy is not a good thing. You have to do anterospectroscopy.
You covered the age-related aspect more, Deepak. But complications are happening throughout our career. Even when we are like. But then you have also touched on the other aspect when some of your colleagues were undergoing divorce, and there were stressful conditions in their life. That is happening at any age, and I think the recognition of emotional health and well-being becomes an extremely important aspect here, which is now if your colleague, because stressors are like your children leaving home or divorce, these are very high stressors. In the psychological science, if anybody has any understanding of psychology, they are considered to be very highly stressful conditions. In our country, we still don't have divorce as so much of a thing, but children are leaving home. And when children leaving home, the empty nest syndrome that their parents go through, that can be also a very important way of causing stress to you. Are you recognizing that stress? And if you are, then what are you doing? Are you taking break from your work during that time or not? Or you're bringing that stressful emotional state to your workplace and then deciding for other people what you're doing? I think that's not fair. And I think awareness, because in your case, as I keep saying, in Western world, in developed world, systems are in place. You can depend on systems, but in our country, it's only education and awareness at an individual level that.
But I want to say two things. One, it's still my country. I'm still Indian. And
sorry,
second
I'm
thing
so
is
sorry. No offense, please.
And both my divorcee friends were both Indians too. And
okay. I've divorced myself, so I know what it is to go with that stress to your work.
Right.
Yeah.
Right. The concept of depending on the system is what we need to erase from our head. These systems have put these mechanisms in place, having learned from collective mistakes. Individual units, even if you're a single practitioner, a consultant to multiple units or whatever you are, you can still have a system in place that can help you with this, these kind of concepts. All it takes is asking for help. And in this era of technology, all it takes is a Google search. So there's all of that. The one piece that I'd like to, if I witness a complication created by one of my fellow colleagues, one of the things that I struggle with is the disparity in the skill set between trainees. And as I mentioned before, there are some trainees who are inherently gifted, and the other one, simple procedure like wisdom teeth extraction. You have somebody that walks in, walks out. They're like, whoa, you're done. It's like 10 minutes. Yes, 4 teeth are out. The other one, a small mammal could reproduce twice in the time they remove, wisdom teeth. And so where do you fill the gaps in skill? And in fact, is the less skilled, less trained person going to have more complications? And as a supervisory role that I am in, I am to blame eventually. We have litigious societies that we live in, whether it's in India or in the US. People are taking up lawsuits more often. I get sued left and right all the time because I have 20 colleagues and all of them will implicate me in the lawsuit. We have a full-time lawyer in our division. That's how heavy our litigious system is. And it becomes really difficult where this youngest, slowest person can have the highest complication. What do you do in that circumstance? And I'm really keen to know what Kita would do or Dr. Dabir would do when you have a young person that's a novice that has a complication.
I can come in on this. Though there's one caveat, Deepak, is that we don't have a system in India where you monitor colleagues as long as you're not in a supervisory position. We are talking about peers, where you report peers for things, and I think that's virtually non-existent. But when it comes to a supervisory role where somebody is slow, as you pointed out, and might get into trouble, I have now had all kinds of trainees with me, people who had some experience when they came in, people who had done nothing and came in, people who had super pair of hands, people who could watch and do it, and people who find it difficult to learn 10 months later. And remember, I just do only a few procedures day in and day out in our team, including me and my colleagues. So, however, I can generalize this, that over a period of time, you can teach these skills to the so-called worst person as well. So what you have to do in that scenario is to go slow, go one step at a time, rather than asking them to, we get some postgraduates who can't give an inferior alveolar nerve block when they are in. So, so we don't allow them to do the impaction. They'll first learn how to give the block. So when you find somebody either lacking or it's taking a longer time to do it, I think it's the best way to overcome this problem. Obviously, we don't have so many litigations that come up as you might, but the best way to provide for this scenario is to go on a graded fashion, take it a little slow. And in the end, what happens is the volume of work they have done by the time they finish is less, but the quality more or less catches up. In general, there can be exceptions. Yeah, it can be quite frustrating at times. And you also might have colleagues who will tell these people that you're good for nothing. What are you doing here? And they can get disappointed and decide not to become just an oral surgeon. Yeah, but generally, if they have a little bit of determination, I have seen that it's just a matter of catching up. It happens. This is my general observation. Obviously, there'll be exceptions to it.
I think it can be an eye-opener for the resident also. If the resident is not able to pick up with the hardship, probably they realize that the specialization is not meant for them.
So,
and they might
this experience, Taranjit, that I'm speaking about is not of residents. That this is about fellows, because residents in our system don't do a lot of hands-on other than minor oral surgery, but it can be an issue there as well. But this summary that I gave is my experience of training fellows for the last decade and a half. I have seen all kinds, some superb ones, some who will be very well known, better known than me in a few years' time, and some who will virtually do very few surgeries. But I'm talking about the process of training them without causing a lot of problems to your patients, at the same time making sure they learn. Remember, when you are in a residency, you're not sure what you've gotten into, So end of the day, you might decide that you will just do general dentistry and you're still fine, You see a lot of people who have done a postgraduate education. So that's fine. But when you're coming in for additional training, that's when it becomes more important that, this is a person who's already determined to do that. And who has a mindset to do that, and these people more or less succeed. That's what I generally feel. Yeah, you got to have patience with them. You got to have patience.
I think what I get from you, Kita, is that it's doing simple things in a more quality way, more extraordinarily, than aiming for extraordinary things and messing up with them. I think it's right that we do simple things, but simple things can be done well, rather than trying to make our profile look better and try to do those things for which we are not ready, or probably they're not meant for us.
And also learn one thing at a time, and that leads to the next step. If you have never done mucosal incisions as a resident, I'm just saying, you're not going to be able to do a nice cleft lip repair with cutting the skin, But if you have never done a fracture fixation, you're going to find it difficult to do a orthognathic osteotomy and fix it, So everything is graded, and you got to go up the ladder. And some people do it quickly and some do it slowly.
Wonderful. Dr. Gopal Krishnan has left two beautiful sayings here, phrases. Making mistakes is not a crime, but relating one is, by Swami Vivekananda. And insanity is repeating the same process and expecting a different result. So I think that's so apt for this conversation. So should we move on to the last bit of this webinar today? And I have one last but one question, that in one part of the this book, that is Computer and the Hernia Factory, Gawande talks about technology, and how technology can somewhere compensate for human fallibility. In various parts, he mentions that. In fact, he comes to an extent where he says that when human beings repeat the same process again and again, we behave like a computer, and eventually our own mistakes will reduce. He talks about the hernia factory in Canada, one place, right? So they're just doing only hernia repairs, and they are doing the best hernia repairs in the world. And it's because the only thing that they do is hernia throughout the day. So all the surgeons have become a hernia factory machines in themselves. So that is also where specialization is leading us to. When we do only one type of surgery, we become excellent at that. And more or less our complications also are only in that. But then we also have support from the technology. The technology is helping us to recognize our mistakes, helping us in diagnosis, and it helps in, whatever we forget, wherever our cognition is not reaching, that is where technology reaches today. So what I want to ask you is, in your experience, what are the pros and cons of so much of technology coming into medicine? We see, especially in 21st century, technology is everywhere, In fact, some of our anesthetists don't even know how to use the ventilators, which look so complicated. In COVID era, so many of our patients we lost because they were just not able to figure out all those buttons on the ventilator. What do you have to say about this?
All right. So let's first talk about the advantages of technology. This book, like you said, was written 20 years ago, but there's another very illuminating book that will talk a lot about the role of technology in the 21st century. That book is called, maybe we should review that another time. That book is called 21 Lessons for the 21st Century. It's written by a historian called Yuval Noah Harari.
Yeah, I'm a big fan of this.
So what Harari says regarding technology and medicines which is going to come in the future. So this is the scenario he paints. It's not necessarily going to happen, but in the ultimate analysis, he says artificial intelligence and automation might at one time possibly replace physicians. That's the ultimate scenario. Okay, because of two reasons. One is artificial intelligence gets better and much better and much better as it does the same tasks again and again, which is impossible for human beings to replicate. So it is possible that you will go and sit in a dental clinic, and I am the manager of the dental clinic, and I have 32 robots that are filling up 32 teeth at all time perfectly. They just do it so well. There is no gap, there is no seepage, no nothing, and then your filling lasts all life. So that is a possibility. The ultimate thing that the technology can do is, through artificial intelligence and automation, is to make our role much lesser, much diminished, if not completely removed. That is in the future. It can happen in 20 years, it can happen in 50 years. We don't know that. But currently, yes, technology is extremely important. Obviously, like you said, you must know how to use it. If not, it will become a problem. I know of many instances which happens in government setups. I'm not pointing fingers at you now, Taranjit, is that there is a vested interest to buy, the latest of equipment, because there is something called as commission, is it, or cut, or whatever, that the guy who buys it gets it. So he will buy equipment for 10 crores. He's not bothered whether he has enough human resources to use them. So that is a problem which is peculiar to the corrupt system, and I don't think we should discuss that here. But in terms of the role of technology, I think it's becoming more and more important. I have a colleague now, Dr. Deepesh Rao, who trained in Australia and is back, and he's making me look like an 18th century surgeon. It's always virtual planning and that computer and this software, and he's asking me to buy a software that will cost 40 lakh rupees now, you know. So yes, and then when the guys who can use technology shine a mirror on you, right? So it doesn't look very good. So but then you have no choice, because they get you more consistently better results. They will make sure that that your delivery of your care is so much better. There may be a cost involved in it, but having said all of that,
there's a huge cost involved in it.
Having said all of that, machines can, this is the other argument, machines can treat, but they cannot heal. That is what Gawande says. So we have to become healers, you know. Well, more machines take up our job, we have to modify and become healers, which means that you take care of the patient holistically, right?
Yeah.
You are the one who actually delivers the care. You just order the machine to do things, you know. So the roles are going to be dramatically changing. There is no doubt about that. And most of the things are for the good. Obviously, we can talk about the ill effects or the cons of that. But overall, I think artificial intelligence in particular, I think Deepak knows more than me. But if I know one line, it is going to make it better, because it keeps learning as it does, and it keeps changing, and more it does, better it becomes. And at a very, very frighteningly improved scale, it can perform. Deepak, I hope you don't contradict me.
Why? I think we should have diverse opinions.
No, but
I'm here to contradict you, by the way, Kita.
This Taranjit is so fascinating to me, you know, that
we have had conversation on Kindle versus reading the books. You know, Kita loves Kindle and I love reading my books.
Right.
You know?
Right. Yeah, I love technology, though I'm not good at it. I like it, no doubt about it. And in medicine, definitely, it is already there. The future is already here as far as technology is concerned.
I just made a new hire into my division, a new faculty, and he's not a surgeon. He's a biomedical engineer. He's a guy named.
I was about to come to that.
Right.
I was about to come to that.
Obviously,
biomedical engineering is part of us now.
Yeah, 10 years ago, I was doing probably about 70 orthodontic cases a year. And every weekend I was in the lab with my residents doing model surgery. And last year we did 200 orthodontic cases and I didn't make a single splint. Right. In fact, we threw out our lab. I don't even know what we did with the articulators and the plaster of Paris and all that. All that is gone. We have saved a lot of time, and that is the cost that we talk about, is the cost of time. What is the price for the time that you have? So there is a lot of technology that will definitely indulge us, whether we like it or not. Google has a product called Lymph Node Master. It's called Lycna or Lina, and that has been proven to be 90% more efficacious than a pathologist reading breast biopsies. Right. So there's no mistakes. In China, the radiologists don't read x-rays anymore. They just look at the readings that were made by the program and then correct the errors. And when they correct the errors, the program doesn't make the same error anymore. So at one point,
absolutely,
there won't be any more errors. We would have corrected every error. Right. What Kita's talking about, the healing versus the treating, is a concept in artificial intelligence called data, knowledge, information, and wisdom. And data is when my watch looks at how many steps I got, how many calories I burned. That's just data. I look at it and I go, okay, today's Saturday. I've already burned 20 calories, but I'm going to have a breakfast with 2,000 calories, so it doesn't matter. That is just data. Without me knowing a perspective to that, putting a perspective to that, I will not be able to transform that into information. And that perspective is, over the last 5 years, how many steps do I take? How old am I today? Am I a male or a female? What's my daily calorie intake? You put information and you get some amount of information to that data. That may take us to the next level. So computers are able to do that. The third level is knowledge. So knowledge is, okay, I have this information on this particular South Asian male who's living in the United States, who is such and such years old, and here you are. But how can I transform that into knowledge? The computer still doesn't know how to do that. Artificial intelligence hasn't even gotten to the level of knowledge. As a human, I know that from studies, I'm at a higher risk for pre-diabetes and cardiovascular issues with my lifestyle, and that I should reduce my calorie intake, have more steps recorded so I can manipulate that data. And that is knowledge. That's the next level. The third one is wisdom, whether I will choose to do that or not. That's the human intelligence factor, which there's no way that an artificial intelligence will come to that in our lifetimes at least. So there are these advances in technology. And then the empathy piece that physicians are supposed to have, believe me, it's harder to teach humans empathy than machines. My dog is very empathetic. He can sense the undulations in my emotions. He knows when I'm happy. He knows when I'm stressed. He knows when I'm angry. My daughters don't, right? So there is sometimes that difference in that empathy is just a perception as well. And so leave alone technology replacing that, we may be able to create an algorithm that suggests that there is this response required to that, but oftentimes that gets lost in translation. Humor, for instance, if you look at artificial intelligence that creates art, if you ask a computer program to write a beautiful haiku or Japanese poetry, it'll never spit out anything that's sensible. It can't create music yet. It cannot paint a picture yet. It can create patterns. If you program it well, it can create patterns, but there's no interpretation of that pattern. There's no intelligence behind that. And that's why it's artificial intelligence. In fact, there's a lot of people that are now, Elon Musk is saying you shouldn't call it artificial intelligence at all. It's not intelligent. And then there are groups that are looking for a body for that. Now think about that as an application in our field is, I can interpret a radiograph when I see a mesioangular impacted third molar. I look at that radiograph and I go, this is a mesioangular impacted third molar. I can identify that. And then I have training that says I need to make a buccal trough, split the tooth and remove it this way.
No, Putta, no. You have to give me the, I need the phone.
A robot to realize that is a mesioangular impaction. Just training it, just showing it patterns of mesioangular impaction. That can be done. I can also create a haptic. I can create a body to that program that will then allow a robot to go into somebody's mouth and cut a trough and cut it exactly that way. Now, this is not science fiction. I'm not making this up. This is happening already, right?
Yes.
So that means that, like Kita said, there's going to be a robot in somebody's office where maybe at a mall you can walk up, get your mouth scanned, figure out you got a mesioangular impacted third molar, go to the next booth and sit with the mesioangular impacted third molar robot. I'll remove it for you at a cost that's not prohibitive. Of course, the problem is the robot will not treat the lingual nerve injury or the complications thereafter, or even an alveolar osteitis, right? So while orthodontics, for instance, has been rattled by this idea of Smile Direct Club. Smile Direct Club is a booth in the local mall. You go get your mouth scanned, you get the clear aligners in the mail, and you wear them and your teeth straighten out. End of story. So orthodontics has been completely replaced by one intraoral scan and a printer that sits somewhere in Brazil or Costa Rica. And that's coming to India, by the way. The creator of Smile, the Smile Direct.
There are no orthodontists in this group, so we can be
right.
Right.
This clear aligner technology is changing the way ortho is being done. And my argument is that orthodontics is not about straightening teeth. Orthodontics is about growth and development, and
Yes.
people that understand growth and development properly can intervene and then correct things. And that's where orthodontics is interceptive and therapeutic. But clear aligners, this company called Smile Direct Club actually has an Indian CEO, and he's a guy from Bangalore that's very innovative. He's totally thinking outside the box, very disruptive technology. Disruptive technology is what we need to worry about. What is going to be the next emerging technology that's going to change the way that we will practice? In fact, the next, I happen to have the honor of being the editor of Face to Face, the IAOMS newsletter. And the next edition coming out is going to be about disruptive technology. So I don't want to give out so much stuff as to what we have found out, but it's scary. It's scary as to what is going to change our world. Well, the con of technology is easy to banter on, but the pros of technology is something that have to be open-minded to embrace. After all, we are not practicing with button bandages anymore, although it still works. And we've moved away, we've moved forward, and that open-mindedness will take us forward even more.
David sir, any thoughts on this? Your thoughts on how the technology has changed the face of surgery?
Yeah, tremendous. Technology is a boon and it should be used wisely. As my friends have said, Kita and Deepak, it is artificial intelligence. You must remember it is artificial, and your natural intelligence should decide which artificial intelligence to use.
Fantastic point.
Choice is with us. We don't be scared, but you must know what to use and what not to use. I somehow feel that basic stuff is what is essential. Like my students, like Kita said, I also have two sets of, they are postgraduate students in the college and qualified colleagues who work with me in my practice. And their, their training method is different, but I urge them that they must use loops. They must not, shy from using a headlight. And, the equipment has to be good. They must have used good quality. I'm terribly basic about all this. We don't have access to softwares to do orthodontic and all that. We have, but our guys are still tottering about making splints and things like that. But what is essential is the basic stuff can't be forgotten. Good use good technology. Don't shy away. We are yet to reach Deepak's level, but the technology is a great boon.
I think technology, the biggest con of technology is that it has complicated our work environment, and especially for a country like ours, it has definitely increased the cost of treatment. I think because of in some ways, like buying the technologies, we are outsourcing, it's fine. But if the institutes have to buy these softwares, buy these technological gadgets, it's not possible. And that cost then gets transferred to our patients. Maybe we will still take time to get there. But at the same time, I was just thinking, while doing the research for this webinar, I also saw Abraham Verghese, another very interesting surgeon from US of Indian origin. And he was talking in his TED talk that earlier, when the ward rounds used to happen, the doctors would stand around the patient and they would interact with patient, then they would talk to each other and discuss, and everything would happen with the patient. Whereas now, in the technological era, the doctors are sitting in their room and they have all these data which is collected of laboratory data and all these, the tracings. If you're doing an orthodontic surgery, then you have a tracing, and patient is somewhere else. So now we are more treating the computer rather than the patient, in some parts. That is how it's just an interpretation that I'm sharing. So somewhere I feel that as a patient, if I am a patient and if I wake up one day after a long surgery, whether I want to see a room filled with various gadgets and technology, or do I want an empathic doctor and a nurse who's standing next to me and telling me that everything will be fine, I think I would choose a fallible doctor to an infallible technology which is surrounding my room. So
I would argue otherwise. I would argue that
Okay.
the young person that comes in to consult with you prefers to watch a video about the program than us explaining the surgery.
Yes. Yeah, totally.
They also will just text you later on how they're feeling. They don't want to see. Like,
Yeah. So I think with that, we have come to an end of our discussion. And do we have any more comments from our audience? Would you like to say anything about this discussion? How do you like it? Or anything? Please share with us your views before we call it a day. Do you see anything, Kita? Thank you. Thank you so much.
Can I say something about training? There's something which took place, a lot of discussion took place about training. Because the simple things like in training, what tells your students or your colleagues or your juniors is how you behave, how you act, how you present yourself in the department, how how you're turned out. Do you wear a mask and cap and you wear gloves every time you examine a patient? I'm terribly basic. Before Corona, there were many people in the department who would not even wear gloves to examine a patient or wear a mask on before examining a patient, or just put a mouth mirror in the mouth and look at. Fortunately, things have changed. Or how you talk to the patient, how do you teach, instead of telling them do this, you have to do what is expected from them. Like we tell children that how parents behave, children follow how parents behave, not what they are told, do this and do that. I think it's very important for teachers and seniors to always behave in a way you want others to behave or others to do things. Do you have I also follow this system of checklist or writing steps of the surgery. Every case, do you do it and do you follow it? All these, lot of things. If you want others to pick up something from you, you got to be happy with your routine, your way of working. Thank you.
Thank you, everyone. We had an amazing time. I hope Kita and Deepak, any concluding remarks before we say goodbye to our audience?
Yeah. So I think we started off with 70. We have 48. That's not too bad, I think. Yeah, it's so much difficult. I hate these online sessions where I can't see their faces. You don't know what impact you're making. Even after 80, still not getting used to it. Your jokes don't get a reaction, so you don't know whether people have understood it. But I thoroughly enjoyed this, and
I told you, technology will never replace a real interaction.
I can discuss the book for a longer period of time, but thank you very much.
Yeah.
Thank you
so much. Thank you so much. Namaste. Namaste to all of you. Thank you.
Bye. Bye.
Bye.